I'm going to introduce Paul Kwo, who's Professor of Medicine, Medical Director of Transplantation at the Indiana University School of Medicine. And Paul, I think, would be recognized as really introducing the subject of post-transplant treatment of hepatitis C and its possibilities. And that's exactly what he's going to discuss today and try and put those arguments across. Thanks, Paul.
Thank you very much, and I would like to thank the organizers for inviting me to talk about this very important treatment paradigm and this era that we've entered. So I thought I would start by just showing that both in North America, and this is European data, how valuable liver transplant has become to our patients with end-stage liver disease. And in Europe, you do approximately 6,000 transplants per year, and it has equilibrated here, and that's not really different than what we do in North America. Setting the stage, of course, is that viral-related cirrhosis turns out to be the most common form of cirrhosis that leads to orthotopic liver transplant in Europe, and particularly when you add it to alcohol and viral-related cirrhosis, it's about 45% of the transplants that have been done over the past 20 years. Of course, there are multiple viruses that can destroy the liver, but hepatitis C dominates, and if you add hepatitis C to hepatitis B and D, you'll find out that it's approximately 70% of the transplants that have been done in the past 20 years are related to hepatitis C in this viral cohort. So hepatitis C is the most common indication for orthotopic liver transplant in North America and in Europe. And historically, the problem has been that hepatitis C recurs universally up until just a few years ago when we developed therapies that could prevent recurrence. And with this universal recurrence was associated accelerated fibrosis as well as reduced graft and patient survival. And this study that was done from our UNOS database by Mike Lucy and Lisa Foreman was an excellent study. It was done over 10 years ago. But what it showed was that when you look at 5-year survival rates in hepatitis C versus other non-hepatitis C related etiologies, that you had a statistically reduced 5-year survival rate that was significant here, as you can see. And all of us who have been in the transplant arena have seen this happen. And occasionally we had dreaded complications such as fibrosing cholestatic hepatitis C and other complications. We learned about the donor being older, leading to worse outcomes. And hepatitis C has, for that reason, always been problematic. One of the major reasons that hepatitis C has been so problematic post-transplant is because our therapies haven't been very good. They weren't tremendous without transplant, but they were particularly difficult to tolerate during the transplant period when patients were already immunosuppressed and perhaps recovering from their orthotopic liver transplant. As all of you know, our backbone for years was PEG interferon and ribavirin, but PEG interferon in particular was poorly tolerated in the post-transplant era. And even in 2011, when we had our first-generation direct-acting antiviral agents, telaprevir and boceprevir, we treated hoping that we would see substantially improved sustained response rates, and we did improve them to some modest degree, but what we also found was that the side effects were magnified substantially. And so interferon-based therapies are poorly tolerated post-transplant. So we've now entered the era of direct-acting antiviral agents that are all oral for hepatitis C. Now, the approach is a bit different than it is in the non-transplant population because of the backbone immunosuppression. And our direct-acting antiviral agents can both be culprits of drug interactions as well as victims of drug-drug interactions. And this is shown in this table here. So what we have in the left-hand column is the backbone therapies that we use currently, and they include ribavirin, ladipasvir, sofosbuvir, cimipravir, decladisvir, and the 3-drug regimen paritaprevir, bidosvir, and dasabovir. And you have here on the column subsequently following this cyclosporin, tacrolimus, sirolimus, and everolimus. And the direct-acting antiviral agents, as it turns out, can affect the anti-rejection trough levels, as AUC levels, but there's only one that's really significant, and that is the 3-drug regimen, which is ritonavir boosted, and that's the paritaprevir that's boosted by ritonavir. And as you can see here in the bottom red row, that cyclosporin and tacrolimus AUCs go up substantially when they're administered. Now, as I will show you, this actually can be overcome with a dose adjustment, but as we look to treat our post-transplant hepatitis C patients, we have to consider both our anti-rejection regimens as well as our antiviral regimens. And this came as somewhat of a surprise. So here we have a table showing the direct-acting antiviral agents as the victims. That is, how do the backbone therapies, cyclosporin and tacrolimus, affect our DAA levels? And you can see here that, as it turns out, cyclosporin inhibits samipivir metabolism in such a way that the AUC goes up substantially. And protease inhibitors, particularly as a class, when their levels get high, are more prone to hepatic injury. And even though in clinical practice we did not observe this, this came out of a registration trial that was ongoing, cyclosporin and samipivir should not be administered together. So now I'm going to just briefly review the data because we've already heard many excellent presentations that cover this, including the SOLAR-1 and SOLAR-2 studies here, which were identical treatment designs, 12 and 24 weeks of sofosbuvir, ledipasvir with 600 milligrams of ribavirin. The only salient feature that really differed the two studies was a higher prevalence of genotype 4. In the SOLAR-2 study, there were just 5 genotype 4 patients in the SOLAR-1 study, even though it was for genotype 1 and 4. And here are the SOLAR-1 SVR rates that I think we've all seen here several times today, but they're shown here, showing that F0 to F3 and Child-Turcotte-Pugh-A patients behave just like the non-transplant patients. You get excellent SVR rates here, and you get very good SVR rates in Child-Turcotte-Pugh-B patients, a little bit lower in C, but again, the cohort size becomes much smaller. Now, a couple of caveats with this. In the SOLAR-1 study, one of the most interesting things was that there were 40 instances where investigators had to adjust immunosuppression doses due to improved hepatic function after viral clearance. So if you're treating these people post-orthotopic liver transplant and once they've cleared virus, you have to watch, carefully monitor their trough levels, not so much for drug-drug interactions, although those have to be accounted for, but also because your hepatic function actually can improve. And indeed, we actually recently treated somebody who was a liver-kidney transplant who achieved SVR and actually developed mild acute cellular rejection of both his liver and his kidney. We were quite surprised. The other interesting part about this SOLAR study was that all the relapses in those with pre-existing NS5A variants occurred in the 12-week with ribavirin arm and not the 24-week arm. Now, again, that's both pre- and post-transplant, but again, we'll have many excellent discussions over the next year and at this meeting about NS5A resistance. And 24 weeks, as we debate durations, might have a role for some individuals, particularly as we gain greater understanding of NS5A resistance. Here's the SOLAR-2 SVR rates, and really, as you can see, the patterns are identical to SOLAR-1. Here you can see that you have F0 to F3 with Child-Turcotte-Pugh-A getting the same high SVR rates. The Child-Turcotte-Pugh-B patients here for both SOLAR-1 are shown here for genotype 4, and that's both pre- and post-transplant. So I broke out here the Child-Turcotte-Pugh-B and C patients here, and you can see that for Child-Turcotte-Pugh-B patients, the SVR rates were really outstanding, and the numbers for C are just too small to make anything of these levels. There was just one relapse in either, and of course that's a preliminary analysis. We've already shown you that MELD scores get better, but that's particularly important in the post-transplant patients because if they continue to decompensate, they're going to need repeat transplants. There aren't enough livers to go around in the US. I'm sure the same problem is true in Europe and other parts of the world. And anyone that we can improve MELD score, and more importantly in the future, improve clinically significant portal hypertension, which is, I think, something in the long-term follow-up studies we're going to have to assess, then we have done these patients a service. And again, these individuals all have been transplanted once. So the majority of individuals do have improvement in MELD scores, particularly in the Child-Turcotte-Pugh-B post-transplant patient population, but again, some do worsen. Safety is also important. These are sick patients to start with, and so you can see here the AEs, serious AEs, as well as the treatment emergent deaths, and there were a few. They've all been adjudicated and to date, none have been implicated with sofosbuvir or ledipasvir. There are AEs related to ribavirin, and of course, there are other deaths that were related not at all to the therapy. But as we continue to treat this population, both in registration trials as well as in our real-world experiences, we're going to have to continue to carefully monitor for safety. Thus far, our therapeutic armamentarium appears to be safe. It just requires ongoing monitoring. So there was also another sofosbuvir-based therapy that was presented this past year, which was sofosbuvir and decladisvir. And this was a single-arm treatment arm post-transplant. You can see the study design was advanced cirrhosis, which will be discussed elsewhere, as well as post-transplant. It was 53 individuals, and they received decladisvir 60 milligrams, sofosbuvir 400 milligrams, as well as ribavirin, again, at the same doses in the SOLAR study, 600 milligrams, and then was titrated if possible. Here are the post-transplant SVR rates here. Overall, it was 94%. It was very high. This was all genotypes, but just 1A, 1B, 3, and 6 were enrolled. And you can see there was just one genotype 6 patient here. But again, there were just single relapses in 1A, 1B, and the 3 cohort. But again, interestingly, all 3 relapses on population sequencing had NS5A domain resistant-associated variants at the time of relapse post-orthotopic liver transplant. And again, safety, we have to keep an eye on safety, but as you can see here, this was similar to sofosbuvir or ledipasvir. This is a well-tolerated therapy, and the ribavirin was the primary driver of medicine discontinuations. There was one individual who discontinued due to a significant headache, and that is something you do occasionally see with sofosbuvir. So, non-sofosbuvir-based regimen is paritaprevir and bidosvir, dasabuvir with ribavirin. And this regimen, as I showed you in a previous slide, has substantial interactions with tacrolimus and cyclosporin. But with dose adjustments, this regimen can also be given quite effectively post-orthotopic liver transplant. So this was the initial 34 individuals who were treated with 24 weeks of paritaprevir, bidosvir, dasabuvir with ribavirin, and then SVR was measured. The tacrolimus dose adjustment was approximately half a milligram every 1 to 2 weeks. In Europe, there was a 0.2 milligram that could be given every 4 to 5 days, and the cyclosporin was reduced to 20% of the daily dose. The ribavirin was typically dosed at 600 to 800 milligrams, and you can see here that the overall SVR rate was excellent. It was 97%. There was one relapse, and similar to the sofosbuvir ledipasvir, sofosbuvir decladisvir, when you relapse with resistant-associated variants, and here the resistant-associated variants were across the NS3, NS5A, and NS5B domains, not surprisingly. The study's been expanded, and now they're looking at F3, F4. The original study was in F0 to F2, and there's also a 12-week duration that's also being explored, and we'll wait a future report on this to see if we can shorten duration. Here are the trough cyclosporin and tacrolimus levels shown here, both pre-treatment and on treatment. And what this shows is that when you do dose adjust, despite the very significant drug-drug interaction with the ritonavir-based paritaprevir, actually you don't really get into trouble as long as you monitor the tacrolimus levels. And again, there were 5 patients that had transiently elevated tacrolimus levels, and these 4 of the 5 had identified tacrolimus dosing errors that rapidly corrected. There were a few mild increases in creatinine that resolved, and for cyclosporin, reducing to 1/5 was highly effective. Sofosbuvir samipravir was the first all-oral combination of 2 direct-acting antiviral agents that was approved in the United States. So like many hepatologists, some of us didn't wait for availability of data to try this out, and this comes from the target group that looked at sofosbuvir samipravir with or without ribavirin in a genotype 1 cohort here, and you can see here an overall SVR rate of 90% was demonstrated in this real-life cohort, and you can see here the breakdown here. The SVR rates were actually well maintained, and even in treatment experienced, as well as people who had cirrhosis and MELD scores above 10, where really we should be very cautious about administering samipravir, as there's not yet good safety data that it can be given in child's B cirrhosis, even though this is currently being studied, and await to see if this is indeed feasible. But you can see here, even this combination did quite well post-transplant, and there's a large genotype 1 study ongoing right now, post-transplant, looking at sofosbuvir and cimiprovir, and we eagerly await these results. In the real world, it performed quite well. So, in conclusion, antiviral management for post-orthotopic liver transplant, I would like to make the following comments. The first is that really no patient should fail post-transplant. Their graft should not fail due to recurrent hepatitis C, and this is true essentially for all genotypes. The second is that survival for hepatitis C infected patients should now approach non-hepatitis C related etiologies. That is, that we should be able to, in 10 years, we should hopefully be transplanting fewer hepatitis C patients, but in our hepatitis C patients, we should expect outcomes that aren't different than other non-viral related etiologies. You have to consider drug-drug interactions, and of course you have to make adjustments, but they aren't that many, and even the dramatic adjustments actually can be tolerated and undertaken quite well with high sustained response rates. For genotypes 1, 4, 5, and 6, sofosbuvir, ledipasvir, and ribavirin for 12 weeks gives excellent sustained response rates. Sofosbuvir, decladisvir, and ribavirin can also be given across all genotypes. And again, we can actually, for genotype 2, give sofosbuvir and ribavirin, though at our own center, now that we have approval in the US of decladisvir, we actually prefer that to sofosbuvir and ribavirin. The combination of paritaprevir, umbitasvir, dasabovir with ribavirin for 24 weeks for genotype 1 is also a treatment option. It's in the package insert, it's for F0 to F2. The EASL guidelines actually include up to F3, F4, and the data is forthcoming. It'll be interesting to see if genotype 1b can have the treatment duration reduced to 12 weeks. I suspect it can. And again, as I'll show you in the next slide, we do need to be thinking about dispensing with ribavirin for some of these groups, and obviously the 1b cohort comes to mind. For genotype 4, we can also give 12 to 24 weeks of paritaprevir, umbitasvir with ribavirin. For sofosbuvir and cimiprovir, for 12 to 24 weeks for genotype 1, don't administer with cyclosporin. The role of Q80K, we'll see what the registration trial says. Whatever the impact is, it doesn't seem to be large when you extend the duration to 24 weeks, though our recent practice guidelines in the AASLD discourage the use of cimiprovir even at a duration of 24 weeks. For Child-Turcotte B and C patients, 12 to 24 weeks of sofosbuvir, ledipasvir, and ribavirin, or 12 to 24 weeks of sofosbuvir, decladisvir, and ribavirin, depending on your genotype. Again, for genotype 3, my own preference is that I would want a 24-week duration of sofosbuvir, decladisvir, and ribavirin. And if you've failed multiple courses of therapy in our decompensated patients, or if we now demonstrate NS5A resistance prior to treatment, we ask for 24 weeks and ribavirin. Must we use ribavirin? Not in everybody. There's also certainly an option for 24-week duration without ribavirin. We use this in our anemic patients, but it also needs to be studied. We've stated several times that in the post-transplant era, we've been married to ribavirin as we have in our decompensated patients. And finally, what role will NS5A play in resistance testing remains to be seen. Particularly, this may become more problematic as more and more people are exposed to NS5A inhibitors. Finally, and I apologize, this wasn't on this slide set that I uploaded, but sofosbuvir and with ribavirin, sofosbuvir, ledipasvir, and sofosbuvir, decladisvir with ribavirin can be highly effectively used for fibrosing cholestatic hepatitis C. And I'm just going to conclude, not to read this, but just to show you that the EASL guideline very nicely, actually, which I found after I did my talk, very nicely summarized what I did, and I encourage you to read this. I think this very concisely, nicely summarizes our current therapeutic armamentarium. Thank you.
Paul, thank you very much. I'm sorry we have to draw the session to a close. I'll leave you with a question to ponder on as you walk out. As will NS5A testing become more important in the pre-transplant and post-transplant groups? But the Janssen Symposium will start in about a minute. I'd ask you to grab a cup of coffee. I'd like to thank all the speakers who addressed these delicately poised questions, and we'll have more answers as we go forward. Thank you very much.